So they also from me in a very well still flash from this lecture gave us a nice view in the future. So I am happy to introduce you now to Professor Witzel, Isabell Witzel. She's a chair of the department of the University of Gynecology, and she's a very well-known professor for Senology. And Isabell, please come. And she will give us a nice overview today for the systemic therapy of breast cancer in the adjuvant and also in the metastasis situation. Isabell,
yeah,
welcome here.
Thank you very much, Danida. Welcome from my side. Thank you for your kind invitation. And I will talk about the systemic therapy in breast cancer, the updates 2024. And I will talk about the adjuvant setting and the metastatic setting, and I'm coming back to the facts of many trials you will see. Those are my statements, my conflicts of interest. Breast cancer is the most common cancer in women. It has a very high incidence, and here you can see some celebrities that were diagnosed with breast cancer or even died of breast cancer. The highest or the greatest risk factor is age. The older patients or women get, the higher the probability of getting breast cancer is. But we have a low mortality, but still 20% of our patients will develop metastatic disease during the follow-up. And that's why we have to identify those patients where we have to escalate treatment in order to prevent metastatic disease, and those patients where we can omit some treatment in order to spare them from getting side effects or long-term effects. And there are two big topics in breast cancer treatment. One for sure is de-escalation, doing less. And that happens in surgery, in breast cancer surgery, but also in radiotherapy. We do less surgery, we do less radiotherapy, but there's also an escalation of therapy, and this happens mainly regarding drugs or identifying patients with high risk of recurrence to give them more treatment in order to prevent patients from getting metastases. So in the adjuvant setting, I want to discuss three topics. First, I will talk about triple-negative breast cancer, then about HER2-positive patients, and then about high-risk hormone receptor-positive HER2-negative patients. If you give chemotherapy in triple-negative breast cancer patients, then you should give neoadjuvant chemotherapy. And that's why, because we know that the information of pathological complete remission, it means that you find no invasive or non-invasive cancer cells in the breast if you do at the time of surgery. We know that this pathological complete remission is associated with a better prognosis. So it's a very important information. And to achieve higher pathological complete remission rates, there's the addition of checkpoint inhibitors to neoadjuvant chemotherapy that is now standard of care. And the trial that has shown this is the Keynote 522 trial. And in the Keynote 522 trial, patients with triple-negative breast cancer were included, more than 1,000 patients, and then they received the checkpoint inhibitor pembrolizumab in addition to standard chemotherapy. Then the patients received the surgery. And then they also had the step of adjuvant checkpoint inhibitor, pembrolizumab versus placebo. And here you can see the sixth interims analysis of this trial regarding the achievement of pathological complete remission. This is a very high prognostic parameter. Patients that achieved pathological complete remission have a better prognosis than those who did not. But even in the patients with pathological complete remission, the addition of pembrolizumab is evident. And interestingly, there was the presentation of the Alexander trial. It was a trial that investigated checkpoint inhibitors in the adjuvant setting after surgery in triple-negative patients, and there was no effect of adding checkpoint inhibitors in the adjuvant setting, and that's a possible explanation. So if you leave the tumor in the breast and then do the checkpoint inhibitor therapy, then you will achieve a higher immune response and therefore a better effect of the chemotherapy. And that's the reason why you should think about doing the chemotherapy in the neoadjuvant setting in triple-negative patients. So we know that adding checkpoint inhibitors has an efficacy, and there is also not enough evidence right now to stop checkpoint inhibitors in patients with a PCR. There are no new side effects, but we have to give good care during treatment and afterwards, because those checkpoint inhibitors, they make dose independent and also timely independent side effects that can be very challenging. So that's why if you give chemotherapy in triple-negative patients, so you should give it in the neoadjuvant setting. What happens with the patients that don't achieve PCR? And I want to show you the Olympia trial. It's a trial in high-risk breast cancer patients with HER2-negative breast cancer, but they had to have a BRCA1 or 2 mutation. And in those patients, they were randomized to receive either olaparib for 1 year versus placebo after the surgery. And there were both groups of patients. One were hormone receptor positive, only 20% of patients, and the majority of patients was hormone receptor negative, meaning triple negative. And in the 4-year overall survival curve, you can see that there is a benefit of 3% for giving olaparib in the adjuvant or post-neoadjuvant setting in patients with a BRCA1 or 2 mutation. And this effect is mainly driven by the triple-negative cohort, as you can see here in the subgroup analysis. But it's a new option or another option to treat patients with triple-negative breast cancer. So that's a possible therapy algorithm for patients with triple-negative breast cancer. You give the neoadjuvant chemotherapy, you add the checkpoint inhibitor, then you have time to do fertility preservation counseling, to do genetic testing. And after the surgery, you have the information about the tumor response, and then you can guide further treatment regarding PCR or no PCR. And those are the options. And in red, those are the options I showed you with the trials, Keynote 522 trial or Olympia trial. And here you can see the Swiss guidelines for testing, and a patient with triple-negative breast cancer below the age of 60 qualifies for genetic testing. Many other options, but in red, those are patients with breast cancer that have triple-negative breast cancer. They should be tested. Now, the next subgroup of patients is the group of patients with HER2-positive breast cancer. Around 15% of patients have HER2-positive breast cancer. And in those patients, the information about achieving a PCR is also very important. So mainly you also do neoadjuvant chemotherapy in those patients. And the question is, what do you do with the information of PCR? And in patients with non-PCR, you can give the antibody-drug conjugate TDM1. And the trial that investigated this situation is the Catherine trial. And I want to show you the updated overall survival analysis that was presented last year. In the Catherine trial, 1,500 patients were included with non-PCR after neoadjuvant chemotherapy. All patients had HER2-positive breast cancer, and then they were randomized to receive either TDM1 for 14 cycles or trastuzumab, the former standard in this situation. And that's the final invasive disease-free survival analysis after 7 years. And you can see that there's a large benefit for adding TDM1 in those patients versus trastuzumab. And you can really prevent patients from developing metastatic disease if you give TDM1. But interestingly, it has no effect in the brain. So the number of patients that develop brain metastasis is almost the same in both at therapy arms. And also with regard to overall survival, there is an effect, a benefit of adding T-DM1 after 7 years, 5% better survival rates for patients with non-PCR and HER2-positive breast cancer. And that's why you should give T-DM1 in HER2-positive patients with non-PCR. The last topic I want to talk about is the situation of high-risk estrogen receptor positive and HER2-negative patients, and there you should think about extended or intensified endocrine treatment. Here you can see a slide from the AGO, MAMA, about endocrine treatment in premenopausal patients, and for sure the standard treatment is tamoxifen. But you have to decide whether the patient has a high risk of recurrence, and in most trials, high risk of recurrence was receiving chemotherapy. And in those patients, you could think of intensifying endocrine treatment by adding ovarian function suppression, or you can also add CDK4/6 inhibitor, abemaciclib, for 2 years, or olaparib. I've shown you the Olympia trial. That's the reason for this. And that's the same in the postmenopausal situation. So patients receive aromatase inhibitors or tamoxifen, but you can also add in high-risk patients abemaciclib or olaparib. And there are 2 trials I want to discuss with you that investigated CDK4/6 inhibitors in the adjuvant setting. And they investigated different drugs. One was with abemaciclib, it's the MONARCH-E trial, and the other one was ribociclib, it was the NATALEE trial. And you can see in green the inclusion criteria and in red the exclusion criteria. And the trials had different inclusion criteria. So in the NATALEE trial, there were more patients included, more breast cancer stages than in the MONARCH-E trial. And here you can see the results. So both trials included more than 5,000 patients. The inclusion criteria were different, with more high-risk patients, only node-positive patients in the MONARCH-E trial. And you can see a difference in invasive disease-free survival that was 7.6% after 5 years in the MONARCH-E trial and 2.2% in the NATALEE trial, but those were 3-year dates, so you can't really compare them. But there was still no difference in overall survival times. But you can see the discontinuation rates are very high in both trials, with 1 out of 5 patients that stop the therapy because of side effects. So it's really a challenge for us to decide which patient will get this therapy. And here you can see the inclusion criteria now in real-world data. And if we would transfer the results of those trials in our real world, we would have to treat 46% of hormone receptor positive HER2-negative breast cancer patients with adjuvant ribociclib. And the problem is that in the trial, there were more high-risk patients than in the reality. So we have more node-negative patients in our real-world setting. And this will be a great discussion, what we do with those patients. Will we give a CDK4/6 inhibitor to every patient that qualified for this agent in the trials? I don't know. This will be a discussion. Abemaciclib is approved now in Switzerland, and we're waiting for the approval for ribociclib in this indication. So those are my conclusions for the adjuvant setting in high-risk patients with hormone receptor positive HER2-negative breast cancer. You could think about intensifying endocrine treatment and giving CDK4/6 inhibitors, and also olaparib in BRCA1 or 2 mutation carriers in HER2-negative or triple-negative patients. But what about metastatic breast cancer? And I told you still 20% of patients with breast cancer will one day develop metastatic disease. And there's a large variety of new agents that came up in this setting and that have been approved or will be approved. And we have to know at least those drugs. So you see SERDs, ACT1 inhibitors, ADCs, antibody-drug conjugates, and tyrosine kinase inhibitors are now something we can also use in metastatic breast cancer. The standard of treatment in the first-line metastatic setting in hormone receptor-positive, HER2-negative patients is giving CDK4/6 inhibitors in addition to endocrine treatment. But we didn't know what to do when the patients progressed, so you get around about 2 years of progression-free survival with CDK4/6 inhibitors in this setting. But now we have new options in the case of progression with the SERDs and ACT1 inhibitors. SERDs are selective estrogen receptor degradators, and one of them is elacestrant, and it was investigated in the EMERALD trial. And patients received either elacestrant versus standard of care treatment, endocrine treatment, and there was one group of patients that had developed an ESR1 mutation as a marker of resistance during the CDK4/6 inhibitor therapy. Those were almost half of the patients, and they had a very high benefit of giving elacestrant at the time of progression. In the second-line treatment, you can see that they achieved 6 months longer progression-free survival with elacestrant. So we have to do an ESR1 mutation testing when the patient progresses under CDK4/6 inhibitors, and then we can try to give elacestrant. So it's approved now in this setting. And there's another option that's now also approved in Switzerland. It's capivasertib. It's an ACT inhibitor, and it was investigated in almost the same setting, second-line treatment after aromatase inhibitor therapy. And the patients with an ACT or PTEN or PIK3CA mutation or alteration had a benefit of adding capivasertib to fulvestrant. And that's how it's now approved in Switzerland. Patients have to have some kind of alteration, ACT1 alteration, but this can be diagnosed also in the primary setting, so you don't have to do the testing at the time of progression because those mutations, alterations don't change during the course of the disease. So it's quite demanding to identify the patients now in the second-line treatment, hormone receptor-positive, HER2-negative metastatic breast cancer patients. Another big group of new agents are antibody-drug conjugates. I showed you the Catherine trial data with TDM1. It's also an antibody-drug conjugate, but there are new antibody-drug conjugates that we use or we will use. We already use trastuzumab deruxtecan and also sacituzumab govitecan, but we might also use in the future datopotamab deruxtecan. There are also promising data. But those antibody-drug conjugates mean that you link very toxic chemotherapy agent with an antibody, and then you manage to get higher levels of the toxic agent directly to the tumor cell, and that's the effect of those antibody-drug conjugates. TDXD as a new ADC was approved, or is already approved in HER2-positive metastatic breast cancer. You give it after at least one anti-HER2 therapy, so you have to give chemotherapy and then you can switch to TDXD in the second-line setting in HER2-positive metastatic breast cancer patients, but it's also approved in the hormone receptor-positive HER2-low breast cancer setting. So there's a new group of patients that have HER2-low, meaning HER2 1++ or 2+ in the immunohistochemistry. But I can tell you that there was a press release of the Destiny Breast 6 trial, and they also investigated T-DXd in HER2-negative patients. So, and it was a positive result. So it might happen that we can drop the HER2 low in the future. I don't know. So, and sacituzumab govitecan, it's approved in the triple-negative breast cancer patient setting after 2 lines of chemotherapy. And it's also approved in the hormone receptor positive, HER2-negative metastatic breast cancer patients after 1 endocrine therapy and more than 2 chemotherapies. And I can show you just a slide from the Destiny Breast 03 trial that investigated T-DXd in HER2-positive breast cancer patients. You can see that the difference between the agent T-DXd and the comparison was T-DM1 is huge regarding progression-free survival and also overall survival. And here's the data of the ASCEND trial in metastatic triple-negative breast cancer patients. You can see that the addition of SG added almost half a year of survival in this group of patients. A large problem in HER2-positive, but in all metastatic breast cancer patients, is the development of brain metastasis. But we know that in HER2-positive patients, 30 or 40% of all patients will develop brain metastasis during the course of the disease. With the longer survival rates, more patients will be diagnosed with brain metastasis. And the first trial, one of the first trials that really included patients with brain metastasis, they were excluded in most of the trials before, was the HER2-CLIMB trial. 50% of patients had brain metastasis, and the HER2-CLIMB trial invested a tyrosine kinase inhibitor, it's tucatinib, and it was added to trastuzumab and capecitabine in the third-line treatment in HER2-positive metastatic breast cancer patients. And the median survival time in the third-line setting was improved by the adding of a tyrosine kinase inhibitor by almost 6 months. So that's also another option in this very special group of patients with brain metastasis, but also with HER2-positive metastatic breast cancer. So to conclude, in the metastatic setting, there are several new agents. I've shown you 2 of them, elacestrant and capivasertib, to treat patients second line. There are some ADCs as chemotherapeutic agents after standard chemotherapy. There will come others in the future, and brain metastases are a relevant problem in this group of patients with metastatic breast cancer. And there are trials like the HER2-CLIMB trial, but we are also awaiting the results of the Destiny Breast 12 trial that investigated T-DXd in patients with brain metastasis, and those might also change our treatment reality in the future, and there's more to come. And thank you very much for your attention. I'm happy to receive your questions.